Alrighty, well, why don't we start? And I expect we'll have some more people joining us over the next few minutes. Welcome everyone to this month's AIDPH Rural Oral Health Echo Session. My name is Stacy Chazen, and I'll be your facilitator for today. Wanted to let everyone know that today's call is being recorded. We'll be sharing the recording on the AIDPH website. Why don't we get started? Jasmine, could you go ahead and share slides? Okay, well, welcome again. So this is session 6, believe it or not, for folks who've been here before. Today's topic is personalized and predictive care. We want to thank our partners, the CareQuest Institute for Oral Health, UNLV, and the Oral Health Progress and Equity Network. Thank you for your support. So our call agenda today, we're going to go over some housekeeping and give you an overview of today's call. We're then going to hear a presentation from ECHO faculty member, Dr. Sean Boynes, on personalized care and predictive methodology. We'll have time for questions and answers. And then we'll have a guest presenter who's going to tap your collective wisdom, talking about a brief screening for intervention and therapy and referral process for behavioral health. And we'll give her some guidance. So as I mentioned, today's call is being recorded. We ask that you type your email and organization name in the chat so that we can capture that you've been here and add you to our distribution list if you're not already on there. All slides, forms, and materials from today are going to be available following the call on the AIDPH website. We ask you to avoid any PHI or PII on this ECHO session to protect confidentiality. And if you have any questions about using the Zoom platform, please chat with Annalise Cothran. Next slide. So I'm not going to read this slide. I think most of you have been here before and are familiar with AIDPH. We encourage you to visit our website if you'd like to learn more, aidph.org. Next slide. About our ECHO, it follows the CareQuest Institute's 3 domains framework using the lens of rurality and health equity, teleprevention, minimally invasive care, and integrated and personalized care. And the idea is for participants to take knowledge gained from this ECHO back to their communities to implement in their organizations, primarily focused on building the capacity of their oral health workforce. Next slide. If you haven't checked out the list of topics on our website, I encourage you to do so. And you can see any updates that we might make if you visit that site. Next slide, please. We encourage you to both be a learner and a teacher while you're here. We use first names to facilitate equality in the discussion. Please, if you haven't done so already, add your pronouns to your Zoom name. We ask that you introduce yourself before speaking. We do ask everyone to keep their video on, but to stay on mute until you're ready to talk and try to avoid any environmental distractions. And lastly, please respect one another. It's okay to disagree, but please do so respectfully. Next slide. So we're going to turn to our first presenter today, personalized care with predictive methodology, with Sean Boynes. Sean Boynes is a dentist anesthesiologist who currently serves as president of Dental Medicine Consulting and the science and research lead at the American Institute of Dental Public Health. Sean's recognized as an oral health leader, has held executive positions and professional appointments in academia, public health, insurance, research, and care delivery. And you could read more about him on our website. So with that, I'm going to turn it over to you, Sean.
Thanks, Stacy, and hello, everyone. Appreciate the chance to talk to this stellar group. Always a pleasure when rural is involved with me. So thanks for having me. Very excited to talk about personalized care and with predictive methodologies. As we go through a lot of changes in the oral health sector, we're seeing the rise of sort of these personalized care methodologies be brought forward. Next slide, please. And the moniker of what is old is new again. Personalized care is not necessarily something that we just recently came up with. It dates back to the Middle Ages and before. Probably most famously, though, is with Hippocrates, who is the father of modern medicine, that it is more important to know what sort of person has a disease than what sort of disease a person has. And that quote really encapsulates what personalized care should be. It's very difficult, believe it or not, to actually achieve that structure, but we are changing. Obviously, personalized care to Dr. Hippocrates was different than, say, a doctor in the 1970s in the good old US of A, and even a dentist who's practicing now. And really what we've seen change through the years is the ability for technology to help. And so the definition of personalized care has evolved to this overarching framework for care that unifies predictive technology and engaged patient to coordinate and customize care to promote health and prevent disease. And in this modern definition, it's that customization that seems to be spreading quickly and with good reaction from individuals and patients. There is this structure called personalized care planning, which is a process to collaboratively develop care plans that are tailored to patient priorities and social contexts, and really is becoming much more important as we see more managed care, more value-based care come into the marketplace. Next slide. I really love this graphic. It's from Avia Health. There's a lot of groups that bring in temporary think tanks or work groups and task force to develop sort of these structures to make it easier to digest exactly what personalized care is. This one really hits because I think it encapsulates everything that you kind of need to make that step into personalized care. And the first building block is sort of this know me, which is centered around an understanding of the individual patient, the individual, or the consumer, for lack of a better word, across different data points. And so the goal is to really be able to create a data architecture that allows the health system and the patient to not really be treated as a generic segment of a population, but to really be an individual who has different characteristics, and being able to apply those data points in a meaningful way, so that the individual feels that there's enough knowledge of who they are, that they have a unique experience with their health and their healthcare. Some questions that come up around NOMI that to determine if personalized care is happening, you should have answers to things like, what historical interactions has the patient had with the health system? What has that experience been like? What do we know about the patient and how they make decisions about their care? How does the patient's culture play into the view of their health? And what does third-party data tell us about their social determinants of health, their communication preferences, et cetera, et cetera? The next building block is Connect with Me, which is really trying to have that connection through the care experience or the user experience, and is usually tailored to individual preferences and based within wherever they're living and what their circumstances may be. Really, the health systems that have been very successful with connection usually have a really good personalized digital experience. So the application on their phone or their ability to get into their system is usually favorable to the people that are using it, and offer different pathways and different structures that allow them to uniquely go through and connect in the care that they have. There's this customer stickiness, and that's for vulnerable populations. It's a marketing term, which is really trying to gain repeat business. So what are things that are being done within vulnerable populations to build loyalty? And are you having the right culturally appropriate structures within the way you're advancing your care delivery in the community in which you're providing care? And then the last building block is Orchestrate My Care, which is pretty self-explanatory, but basically having a tailored structure of how this care gets oriented. I always think of this old TV show that was on the USA Network called Royal Pains, where he was this concierge doctor, I think in the Hamptons or Martha's Vineyard. And at any beck and call, he would come out and provide care. He had regular house visits, but he was kind of like a personal doctor, knew everyone and what their needs were. Why that can't be for everyone, having experiences that feel like that are really what people want in the orchestration of their care. Next slide, please. So those are sort of building blocks that allow us to have a good understanding of where we need to be and how to move forward and how to start structuring the thought process around personalized care. It does get confusing with all of the P words that are out there. So I kind of wanted to include this particular article because I feel like they've really captured the fact that there is just a lot of pieces that get thrown into personalized care, and they all make sense, like precision medicine and individualized medicine and
मी
personalized
का बोलले माहितीये तुला मला
and
अगोदर साइन अप
stratified
किती लोकांनी केले
medicine. And so all of these things kind of fit within this dome, and it's true, they all really do. However, I wanted to include this slide to say, hey, if you're confused about what P word kind of goes here, there's a reason for it, that we're trying to encapsulate a lot of different things in the personalized care. And the reason behind that is because you really want to have the most efficient toolbox, whether you're providing care directly to an individual or working within a system to make it easier to get health attainment. You have a toolbox that you need to be able to pull out depending on what location you may be and what community you may be dealing with and what the individual needs are and can be. Next slide. So when we talk about the future of personalized care, it really looks like a virtual experiencing. And the main thing to sort of take home from this slide is that when the individual starts to have data that is predictive and they're starting to get algorithms that encompass their entire health, when you think about the healthcare system and you think about getting care, it's either 1/5, maybe 1/10 of overall structure of health. And so when you think about it that way, all of the data that's coming in, all of the care delivery, we're going to expand beyond just what the disease is and into what is this person's health. And in doing so, we'll start to see more of the platforms like what you see in front of you, which is an individual will have advanced analytics within their phone or within whatever iPad or whatever technology they choose to have. And they'll have a health plan platform. And all of this data, including things like payment and how they're consuming different products to how it's tracking their daily life activities with things like a Fitbit, all of that's going to get incorporated into health. And so the idea is, from a personalized perspective, how do you plug into this data to inform the process and coach more effectively for the individual to understand what habits contribute to good or bad health, what healthcare is working effectively to them, and all of the things that you see in front of you that really tie into health as a whole body mechanism. And so really trying to understand these entire platforms will allow for the individual, the care delivery system, to be able to advance into something that is very similar to, say, YouTube or Netflix or Spotify, where based on your behaviors, it starts to accumulate data and can provide you through an algorithm things that can improve your health, things you're doing that are not helping your health, and provide suggestions, just like you get ads on Amazon or within your Facebook feed of things you may or should like. Same thing will start to happen within your health structure. And that's all part of this personalized structure and system. Next slide. So one of the main drivers around this personalization uptick is really empanelments. And so as more managed care organizations are becoming involved in overall healthcare, we're seeing much more of vision and dental and hearing and different types of behavioral health all coming into sort of one organizational structure for reimbursement. Empanelments become a big driver. And so what an empanelment is getting assigned a certain group of patients. So you can be in a certain county, for example, be a provider in that county, and every patient that's on a Medicare or Medicaid plan could be assigned to you. And you're responsible for all of those patients. And that's really what empanelment is. There's different structures and algorithms that different health plans use in order to assign. In dentistry, we really have not done this as fully as medicine has, but we're starting to see where this is occurring more and more. And so once you have these assigned patients, you will start to become more responsible and have more risk in order to keep them healthy, right? Because if they're assigned to you and you're starting to be paid for that assignment instead of the services that you provide, instead of the filling that goes in or whatever service you may provide, you're going to lose money if you continue to provide the service. For example, if you have somebody who gets a cavity and they've been healthy for a year, you weren't really counting on that expense, which you're now responsible for as we see this financial part of the system goes. And so that's what's really driving a lot of personalized care is how can you reach out to an individual and make them healthier and thus reduce their cost and need for services because it saves money on the back end. Next slide. And so that's my basic introduction to the money machine. It exists. If you're going to provide care in the United States, you're definitely going to run into what I call the money machine or the capitalistic system that sits underneath the structure of US healthcare. Next slide. And so a big driver, as I said, with the empanelment structure is just sort of this change that we're seeing more in medicine that's having sort of a tangential effect in dentistry. But we're seeing a movement into much more of a quality-based payment structure, being paid for health outcomes as opposed to health services, and the old adage of you're being paid more for the value of the services and the outcomes as opposed for the volume. And what you can see here is there's 4 categories. Category 1 is fee for service, which is that traditional, I do something and get something back. Category 2 is still fee for service, but there's some link to quality and value. Most of the first steps into value-based care sit within category 2. That's pay for performance or getting paid to do certain quality process measures. Category 3, you're building on a little bit more risk. And category 4, you're full bore into accountable care organizations and things like that. The main drive of this slide, as you can see, we're decreasing the amount of fee for service, which means we're becoming more accountable for outcomes in some way, which means the more loyalty and the more personalized we can get to make somebody healthier, the more money that's saved. And within these financial arrangements, it means there's more money for everyone, so there's profitability. Next slide. So in order to do that, as you take on more risk, you need to get more predictable in structure. And one way to do that is to start to risk stratify a population. That's why we've seen such an uptick in trying to get caries risk and periodontal risk assessments done, starting to see more reimbursement in dentistry for the codes 0601 to 0603, which are those high, moderate, and low caries risk. And the reason that we want to do that is by stratifying the population, it allows us to get more personalized in the structure because we're starting to understand where the risks are at. But not only that, we're having a conversation with the patient to understand what habits are contributing to the disease being there. And that moves away from traditional dentistry in the sense of traditional dentistry is disease present? Do I need to do anything about it? If I do need to do something about it, I'm going to do surgery by removing diseased tissue, either on the teeth or the gums, replace it if I can, or hope it heals effectively to replace. And so moving away from that, you need a way to have a discussion with your patient, which is, here's the bad things, which are those disease indicators and risk factors. Here are the good things. How can we balance these things out in a better way so that you have a better oral cavity? Hit the button for me one more time. And we have different mechanisms that are out there. This is for caries risk. There's several forms. Probably the most popular is Canberra. But there are others that are used. And there are periodontal risk assessment tools that are present now. There are some issues within the dental sector of being able to risk stratify effectively. Next slide. Which is we're not really aligned on the dental side with what's happening in medicine and behavioral health, where on the dental side, we basically have 3 risk stratification areas, low, moderate, and high. In the medical and behavioral health side, they're usually 4, and it's to determine if somebody is going into rising risk. The other thing that's a little bit more prevalent on the medical side is looking at other things that tie into risk besides just the presence of disease, things like identifying social determinants, patient-centered medical home, and behavioral health integration. It kind of all factors in to the type of care an individual may need based on risk. So if you think about personalized care, understanding where their disease risk is at allows you to understand how to more effectively treat and change behavior on the back end to be able to hopefully provide the level of care that the patient needs and start to reduce the cost. For example, if you're a super utilizer, you usually have the highest risk, you're going to cost the most amount of money. So when we talk about personalized care, there is a financial component that comes into it. And a lot of that can be eliminated if we risk stratify so that we don't become too biased in approach. So next slide, or hit the button. So the idea would be, if you look, here's how the care management works. If you're prevention and wellness, if you're low risk, you don't need as much. As you get into higher risk, you're going to need more hands-on coaching, more connection with your healthcare system. And so that does end up resulting in more money. Next slide. Here's my cynical slide for everyone, which is, while we want to drive to health, and personalized care does have the ability to make people healthier and make people feel better, there is a drive to make sure we know how much things cost. And so when you look at risk stratification from a disease process, there's a lot of similarities to risk financial pyramids, which, if you think about your foundation with your savings and T-bills, those low risk things, that's your healthier patient. When you get more risk and more unhealthy patients, then it becomes speculative. And so the idea is to develop a personalized care structure that allows you to meet these individuals where they're at within their disease burden and provide them the level of care that they need. And so it's really foundational from a financial standpoint to be able to continue to be able to afford it and pay people to be able to do personalized care. It's also important in order to be able to understand what they need from a health perspective. Bad news is we're still under 15% of doing risk assessments in dentistry. Next slide. So grouping or personalizing, some barriers to implementation. Here's some warning signs and things that right now are interfering with our ability to really realize personalized care. Next slide. So one thing is there is a desire to generalize and unitize, some for good and some for bad. One thing is it's important to feel included in society. And one of the things that we do within society is be able to purchase things, to be able to go places. It does cost money. And so you start to see marketing and advertising that can reach out to certain segments of the population. And in doing so, they're trying to draw them in with advertising because they think they'll buy the product. This is good for this segment of the population. What ends up happening though sometimes is a lot of that value or that generalizing can start to seep into healthcare, and it makes it more difficult to be able to break the person away. If you're getting lots of data points on how they fit into a segment of the population, it's really easy to generalize that everyone that fits within that segment ultimately is the same and can have the same boilerplate treatment plan, or they're going to have the same outcomes as everyone else that sits in there. And so there are names for these things. Next slide. One is unitization, which we should be familiar with, and there's going to be a lot more of that. So as providers or individuals working as advocates or trying to change the system, it's really important to understand, hey, in mathematics and business, unitizing helps. If you're a researcher out there listening in, it helps because it makes these smaller equal groups where we can start to see, okay, where's the impact and differences? But what can also transpire out of unitizing is diagnostic overshadowing. Which can, there's lots of research on diagnostic overshadowing. It's growing. We've seen a lot more in the recent years, but it can result in biased treatment plans, can result in individuals being over and under treated. A couple of easy examples, individuals with disabilities tend to be over sedated in the treatment of dentistry because they're usually grouped within a particular segment of the population, or tend to have undertreatment because there's a thought process that they can't be seen in the office because they're not cooperative, when most research shows that 75% of that population can easily be treated within a regular dental practice. Next slide. One of the other barriers that we still are not addressing that we'll need to is who owns all of this data. I showed you that big piece. There's 5 data sets coming into an individual's phone. There's algorithms. There's lots of proprietary mess that's going on right now. But believe it or not, there's hardly any ethics and hardly any guidance or platforms to move forward on exactly how to start looking at a lot of these algorithms and predictive technologies. So there's a review, about 500 industry insiders basically thought the healthcare providers are going to be best positioned to access individuals with existing health problems. Tech companies are probably going to have an edge with prevention. 3/4 of respondents believe that owners will be the individual patient. But what's interesting as these things have come out and more of the applications on your phone are starting to come to fruition is that it's the customer experience that becomes more important. So that personalized experience we talked about earlier, as opposed to perceived health benefit. Next.
Sean, I need to give you the 2-minute warning.
Good. Next slide. Just a couple pieces. Want to give this report out. This is key to the rural health approach, which is basically saying, hey, in order for the rural environment to really get effective change and stop some of the bleeding that's occurring, is to have more personalized experiences, understand how they can customize with where they're at. And next slide. Another great article to provide for your review. This is looking at the Veterans Health Administration. They enacted 4 different personalized treatment planning approaches. They found a lot of issues and a lot of problems being able to do so. There's a couple of different approaches to look at, like everyone is a village, and the health coaching pieces seem to be able to enact personalized care better on that front. The downside with health coaches or using community health workers is they tend to end up being the only ones who end up using the personalized approach. And if they leave, it's really hard to replace them as champions. Next slide. Really quick, because I have about 30 seconds. Next slide. Way you can look at oral health. We understand where our microbiome sits. These are all of the individual bacteria that sit in your mouth that relate to different diseases and different processes. We now have, next slide, salivary diagnostics that allow us to evaluate this microbiome, which can allow us to customize approaches based on somebody's individual single cell makeup. Next slide. And will allow us to plug in more effectively into this virtual experiencing. So things like coordination of care, things like understanding what the individual needs and closing care gaps become much more important within this structure. That's it for me.
Thank you. Are there any questions for Sean? Feel free to post in the chat or to take yourself off mute.
I have a question. As you're looking through this information, where do you feel like the first place that people can start? If you're on the lower end of the spectrum and you're looking to really take the first step in integrating a personalized and predictive approach, where should we start?
So I like the first slide with the building blocks. It's from Avia Health. There's other groups. I don't have any personal vested interest in Avia Health, but I like it because if you look at that source, which is you can click on the link at the bottom of the page of that slide. They actually have questions that you need to ask yourself and get answers to before you can really move past that initial stage. And so there's a list of, I want to say 20 questions or so for each one of those building blocks that you kind of need to work through. And that's probably where I would start.
Great, thanks. And David.
Thank you, Sean, for a very thoughtful presentation. I wanted to get your feedback on a situation that I'm observing anecdotally. So I don't have any data to support this, but I see it happening more and more, and I hear my colleagues, my physician colleagues, talking about this more and more. So what I'm seeing now is disparities in healthcare delivery. Not that we haven't seen them forever, but one where people are seeking out concierge services in medical care. And so we see a number of more affluent people seeking out concierge health services. allow physicians to provide a more personalized care plan for patients. On the other hand, my physician colleagues who work in different types of practices talk about how limited the time is that they have to spend with patients and how little they can actually provide care. Care needs, not only, talking about expanding the spectrum. So I'd like to get your feedback sort of on where this is heading, what your thoughts are related to if you see this disparity as well, and whether or not you think how this might impact more personalized healthcare.
Yeah. So to me, for me, what comes up is sort of the spectrum of restaurants. And I feel like that's sort of where we're heading. So you'll have sort of at the more affordable end, things like Wendy's and McDonald's, and the big drive, and a lot of dental service organizations are driving to this, is really good quality control, right? Kentucky Fried Chicken, McDonald's, Burger King, you go in, you know exactly what you're going to get. You do not have a lot of choice. You have some choice, but not a lot, but you know exactly what you're going to get. And for some fast food, it's the minimal standard, and I've eaten at those restaurants, and some it's a little bit better class. So you have sort of a spectrum. Then you leave that fast food, you may go into sort of casual dining, your Applebee's, your Olive Garden, a little bit better quality, you get a little bit more of a personalized experience, right? Because you have somebody waiting on you, you can go in and sit down, you can probably change the menu, into your 5 diamond restaurants. And it really is going to depend on how much money you have and how much money you want to invest. And the other piece that's interesting I'm seeing on the medical side is it doesn't always fall into how much an individual makes or earns. It's that plus how much they value health and healthcare and how much they want to go. Like, for example, individuals that tend to want to have 3 dental cleanings a year, they're going to invest more money to maybe go to the Olive Garden or something like that. I think the concern is, what is quality control? And then what do you fit in? We're very close to primary care now, where you have to fit in more things than you have time for. And now you have to choose. And if you're in sort of the lower end, you're going to have less time and there's going to be less personalization. But if it's concierge and you're spending the money, they're going to customize it for you and probably allow you to develop your own plan. That's a good question, David. I could talk about it for an hour.
Thanks, Sean, but we can't let you and that's a great segue, because we're now going to transition to our case presenter for today, Dr. Mary Beth Schaefer, who is dental director with Community Action Agency of Columbiana County. She is a rural dentist and a rural program administrator located in Lisbon, Ohio, and we thank her for joining us today.
Thank you for welcoming me. I'm going to do a little case presentation and ask for feedback from the audience and group to help me solve our problems here. We're on a journey to full integration with medical, behavioral, and dental here at our FQHCs. And we have 3 locations throughout the center, and we are all integrated, some within the same building, some without being integrated within the same building, but we all use the same electronic software. And so the dentists use the electronic health record for our check-in of every single patient, where we record their blood pressure for our physicians. We look at their labs as far as their HbA1cs. And then one of the final things we do for behavioral health is the SPURT. And for those of you not familiar with that little acronym, it's a screening for brief intervention for referral and treatment, and the PHQ for depression screening. So prior to beginning the dental appointment, we would do these little brief intervention questions to see if the score warrants that the patient might need referral to our behavioral health faculty here. And we ask then the front desk for scheduling with the behavioral health. Now, some of the issues that we have encountered is that not all the behavioral personnel are skilled in all patients. So some may do medication-assisted treatment, some may do child, some may not be able to bill Medicare because you have to have certain credentialing for Medicare, and some can take all the patients. And so we don't want to elucidate the problems to the front desk too clearly, but that they need to be scheduled with behavioral health. But then they would have to go into the spurt to see exactly which practitioner might be able to handle some of these problems. And then once the behavioral health practitioner does assess the individual, the provider's notes for behavioral health are locked to everybody else on campus for confidentiality, things that are shared in counseling that they may not want all of us to know. And so we are basically closed out of the loop on where this is for the information. And then the patients can be put on medications to control the symptoms that typically disrupt the salivary flow and increase the caries risk, and we may not be referred back to address those issues. And fourth, we get communications between providers to determine the best timing and sequence a dental therapy in this treatment process. So those are some of the issues that we've encountered. Next slide. And so some additional information on where we're at. We're at rural Appalachian County. The income is low and there's a drug abuse program, which is our problem, which is a growing concern. We have greater than 35% of our patients with no dental insurance, creating a health inequity for our dentists and our dental patients. And studies say that the recovery is stronger for patients who experience improved oral health, and some of these people are not able to obtain good oral health. We do have a sliding scale. We're at least fortunate for that. But for some of the patients, even a nominal fee of $35 can be quite an expense for their monthly income. So my group ask is, what can the dental providers do to improve communication without violating the patient's right of counseling privacy? And the current proposed plan of action that we're thinking about is we'd like to set up an in-service with our medical, dental, and behavioral health providers to brainstorm ideas for improved integrated care. And of course, we've met with some resistance, mainly time. People are very, very busy and they have a lot of other concerns, and they see this as maybe a lesser priority. Next slide. So this is just what we do in our practice here, and medical does the same thing. And so we ask, have you had 3 or more drinks in a day? If you hit 1, or if you've used recreational drugs and you hit 1, you'll see, next slide, please, that a series of questions come up. Next slide. So those are the questions that come up, and they talk about the frequency and whether you've had blackouts, whether somebody's mentioned you might have a problem. And then these scores are then tabulated automatically within this spurt. Next slide. The same happens for the drug. Next slide. And then the same thing also happens for depression. And so if in fact we open the PHQ-9 and we ask these questions, it will score it. And then it'll say there could be a moderate problem, maybe suggest that you see a behavioral health. And then we ask the patient, would you be interested in doing that, pursuing that? And then we try to arrange care for the patient. Next slide. Okay. So that's our problem, that's our ask, and we're looking for some group discussion to help us build a stronger unity. If we go through this effort and we take all this private information, we want to make sure that the patient's being cared for, but also, are we caring for their oral health in this journey?
Thank you so much for that. So Jasmine, if you could take us a few slides forward, please. Keep going. Oh, back up. Sorry. Okay. So we usually have a slide in there that asks for clarifying questions. I apologize, that's not in there. So let me ask people before we go into our 2 separate rooms, does anyone have any clarifying questions for Mary Beth? What electronic health record are you using?
We use NextGen, and we use the companion dental piece to NextGen.
Any other clarifying questions?
I know you said that for behavioral health that once the notes are locked, you can't access it. Is behavioral health able to go in and look at a dental can they go in, could medical go in and look at a dental chart, and can they access that information?
Typically, they would not go into the dental chart because it's on an electronic dental record and you have to have access. And I think that for each provider to get access, there's an additional fee. But we put our treatment plan within the electronic health record, and all of the intake notes from that day with their blood pressure, if we did a blood glucose screening because we have a diabetic and we're going to be doing some work and we might be concerned about that, that would all be available to them, along with what was the patient's point, why did they come in for treatment? That's all available as well.
Awesome, thank you.
What does the process look like when you identify you want a patient to see behavioral health? Do you just send them with a letter or a note up front and they make contact, or do you pull a staff member back?
We task it to our front desk. We use central scheduling here. And so we send a task electronically through our private email to say this particular patient needs to be seen, and we use a reference of a spurt. Or if it's a PAQ.
Question, why are dental personnel locked out of the behavioral health information?
Medical are as well. The behavioral health information, very many times that in counseling, you'll reveal something that is just between you and your clinician. And so those notes for behavioral health are locked immediately after the clinician has seen the patient, and that is a right of privacy.
Anything else? Clarifying wise. Okay, so we're going to go into 2 rooms now. The ask to consider again is, what can the dental providers do to improve communication without violating the patient's right of counseling privacy? And we will post that question in the chat so you can continue to see it. You're going to have, let's say, 11 minutes in your room. So by the time you get there, let's say it'll be 1:44. We're going to come back at 1:55 to do some brief sharing out. So Annalise, if you'll send us into breakout rooms, half of you will just stay here and the others will see a breakout room invitation pop up. Okay. Great. And Annalise, do you have the slide deck open to be able to grab that question?
I sure can. I'll post it in the chat.
Thank you very much. So I'm going to be your facilitator for today, and Annalise is going to also capture notes. We have a few of our faculty members here as well. So do people have thoughts on the challenge?
I think it might be helpful if you could have a single I don't know how many providers you have, but a behavioral health case manager that could be the point of contact for these referrals, and then bridge that communication gap back to the dental care team.
And Mary Beth, feel free to respond with any feedback or follow-up questions.
I'm not sure. I'd have to get together with behavioral health on whether they have a case manager that could also assume this duty. I don't think that the duty would be one that could employ a full-time case manager, and it would be episodic. So I'm not sure how we would fit that in if there weren't already an existing case manager with time to assume this duty.
That might be a place to explore in your health center to see if there's something existing, and if there's not, maybe reach out to medical, reach out to behavioral, see if there's a need for this kind of position that you could potentially all share, and just kind of work from there to see what other needs are, and maybe even plan for like a future position and someone who could take on that role. If there's need elsewhere too, that could potentially employ someone full time. And if you have the resources to do so, of course, that might take planning. And is not an immediate answer, I don't think, but at least getting this conversation started, I think, is something you do right away.
We have a brand new position, and he handles all warm handoffs for medical or dental if we get positive responses on these questionnaires. And I don't know too much what that position looks like. I know it's brand new. He just started, and behavioral health's really excited to have him.
I could see that working here as well, that one position maybe serves 3 different organizations, dental, medical, behavioral health, and that would certainly help the patients, I think, because sometimes they get lost in the system.
And do you know, would there be Medicaid reimbursement or insurance reimbursement codes for that type of role for, I guess, for that case, care coordination, case management, whatever they might call it?
That's a really good question. Unfortunately, I don't know too much about it, but I can try to find out.
And Miranda, what state are you in?
Missouri.
Missouri.
I'm curious about the team huddles. Do you routinely have morning huddles or huddles throughout the week where all of the different practitioners get together? And maybe that is an opportunity to discuss behavioral health among all of the different teams?
No, we do not have team huddles. The organization is dispersed throughout this county, like in 3 different locations. And so we don't have like a Zoom meeting going over charts or people that are coming in or anything that we could discuss.
Do you do any follow-up surveying to your patients after they've come in for a visit? I'm wondering if, if there was a survey that you do that's texted to your patients, for example, to find out, did they go to the referred visit? Were they able to make an appointment? Did the visit happen? To get some direct feedback from them, which I know would not be a 100% response rate, but could give you, some sense of whether the counseling and referring that you're doing is having a meaningful impact on their follow-up behaviors.
Yes, no, we do not do a survey when the patient returns. Of course, we repeat the spurt to see if they have been in treatment, where they are in that, and we follow all referrals. So even to another clinician dentist, we would follow that referral. So we know whether or not the referral was actually satisfied, meaning that they made an appointment. But we don't know the outcome of the referral, nor do we know, until they return, and it's just by what patients state on how it's going.
Okay.
I want to step back a little bit to what Annalise talked about, because I as a dental educator for a long time, I think this is an important concept. What I find is that, so we have social workers embedded in our clinic, in our university clinic. And I often find that even though we talk about this in didactic courses, our dental students don't truly understand what other professionals can do and what their responsibility and what they can do for their patient as well. So I think having those kinds of in-service or that level of interprofessional communication is an important one. And as we all probably know, we work in such a siloed environment. We don't often have those opportunities. And so I think that might be something that would help to improve that communication as well.
Thanks, David.
I know, Mary Beth, you mentioned, you were potentially planning an in-service, but it's been hard to get time to do it, capacity, and buy-in from providers. So I think that might be something that has to be worked on up front, especially, if you may want to implement team huddles or something, or an in-service in the future. But I think too, just talking to the providers that would be involved, or other staff, of course, understanding what their goals might be for the in-service, what time, and what activities might work best for them, get their feedback and their opinions to plan something that seems really meaningful to them, and start to get them bought in the planning process. I think could be really helpful. And I really do think you'd be surprised once you get maybe 1 or 2, done and completed. I think you'll really see more buy-in, but it's really difficult to get over that hump in the first bit of the process. And I commend you for trying to do so.
Well, we're kind of in a bargaining position now because the physicians are required to do the fluoride varnish now as part of their wells visits. And so they're a little squeamish on that. So I've offered to help with that and to train their medical assistants to do that. And so now I've got a little leverage to get this little team huddle going with what we need now.
It's perfect.
And
All
not
right.
that I'm without using leverage.
One thing that's interesting to me is when the dentists are doing the screeners and they're kind of incorporating it in, do they take the approach that this is going to help this patient's oral health or help me treat the patient's mouth? Or are they seeing it as just a mechanism for behavioral health and they're doing this for them to drive business in? Do they see the connection that the mental unhealth and depression causes increased cortisol levels, which impairs.
Dentists are well
ability to
aware
heal?
that they are behavioral health scientists, right? They start with motivational interviewing and they do systematic desensitization every time they see a child. So believe me, we've been mental health advocates from the very beginning. And so we also understand what happens with depression is physical neglect. How are we going to get somebody to do things to care for themselves if they don't value themselves right now? They're so depressed they can't get out of bed. It's highly unlikely they're going to brush their teeth 2 minutes twice a day with fluoride paste. So we understand that without good mental health, dental oral health is never going to be achievable. So we see it as very instrumental. And of course, somebody that's abusing alcohol and drugs typically is, and I shouldn't be saying it across the board, but typically they're abusing tobacco, and we do a tobacco cessation here as well.
Any other thoughts?
One thought, Mary Beth, which is, have you taken, to Stacey's question earlier, whether or not you've done a survey, but even just maybe asking patients during the care visit what they would like to see during their dental visit as it relates to their mental health? I'm curious if maybe it's just kind of taking a straw poll of patients and saying, hey, how do you feel like I could help you with your mental health as your provider? And maybe starting there with some ways to just infuse that into the patient care visit.
We try to get our patients involved in goal setting. So many times in an FQHC, what initially brings a patient in is a crisis, right? They have a toothache, or they have something broken that's sharp and is going to cut their tongue, or they found this lesion. So they're in somewhat of a crisis. So the anxiety is usually high because the reason they're in crisis is there's usually some avoidance going on with dentistry, whether that's fear. I don't believe most of it's economic here at the FQHC. It's probably more fear or a lack of concern for themselves. So we start with all these questions, to see, okay, where are you? Where are you on the spectrum of whether or not I could even treat you today? Should I just do something palliative? What should we do next? So we try to involve them in that, because you certainly don't want to make this another prophecy fulfilled and then we don't see it for another 20 years. And so if it becomes a bad experience, that's what will happen. And we're trying to integrate their oral health into their life.
Well, I want to just say, I think it's actually really innovative what you're doing. There are many other practitioners who aren't viewing this in the same way. I feel like I've just learned so much from what you're doing too. It's really great that you've been able to get as far as you have in the care integration process.
We have a great team here. I am very, very, very blessed with the dentists that work here, as well as the hygienist and assistants and AFDAs. And it's a team effort because we all understand that we've been given the responsibility, not just for ourselves, but to help somebody else pull them up. And if we each just pull up 1 or 2 a day, imagine the impact it could be on our county.
Great, thank you. So welcome back, everyone. I think everyone should be back from the other room. We had a nice conversation here in the main room where folks stayed, and Mary Beth was here. So I'm wondering if folks who were in the other room, if anyone wants to share some highlights, some suggestions that were made there, noting that Mary Beth will receive a full summary of the recommendations that were made in both groups. But anything folks want to highlight? Hear about a couple ideas that were raised in the other room?
Hi, Tony, I'm happy to share out from our room if that's okay. Hi,
Yeah,
everyone.
yeah.
I'm McAllister. I keep forgetting to introduce myself. I'm McAllister. I'm a dental public health resident at the University of Iowa. One thing that we had talked about in our room, one of our members had brought up, while we understand that there's concern and challenges and being respectful of everyone's time, that we do need to find those champions within the organization that are going to be willing to help streamline that process and identify what information is going to be valuable to each member. To what does dental actually need to know about behavioral health? What does behavioral health need to know about dental? What does medical need to know about everyone that's involved? So how can we be more efficient in providing summaries of care and care plans moving forward? I had brought up that I know it's not with behavioral health, but when I was in my GPR and we were treating our cancer patients, understanding treatment timelines. So while I wasn't necessarily privy to my patient's exact cancer treatment, I had an idea of they're going to start chemo on this day or radiation on this day, and there's a frequency of appointments. So if this is going to be happening more frequently, they're probably not going to be available for dental treatment in the same way. And thinking, being able to just coordinate, especially if there's an opportunity for co-location, which Mary Beth, I wasn't sure how co-located behavioral health is with dental, but if there's an opportunity that schedule permitting, they can come and have their dental and maybe their behavioral health appointment the same day, or maybe because they're having a more traumatic dental treatment that day, that maybe we shouldn't be scheduling that the same day that they're going to be seeing their counselor. What, being conscious of what the patients are going to be able to take psychologically, because there's a reason why they're in behavioral health as well, and there's a reason why they're in the dental chair, and it could be very mentally taxing for a lot of reasons.
Thanks, McAllister.
Yeah.
So Jasmine, we're just about at time. Could you reshare the screen so we can go over some next steps? I want to thank Mary Beth again. Thank you to Sean, both of you, for your great presentations, and everyone for the engaged and insightful contributions you made. I want to remind everyone that CEUs are available for today's session. AIDPH will send out an evaluation request form following today's call. Recordings and resources from today's call will be available on the website. We'll also post the recommendations that came out of this discussion. Our next topic in August will be mental health and oral health, and we'll be confirming that date shortly. Be on the lookout for that. And we encourage you to share if you have some organizational or community or clinical problem that you'd like this group to give you feedback around. Please submit an application to do that. You also have an opportunity to earn a rural oral health certificate, and we're at time, so I'm going to say read all the details on our website, and thank everyone for joining us today, and wish you a happy Thursday.
Thank you all for sharing your insights with me. I'll take some
Bye,
of those
everyone.
back.